Thank you, Chairman Lips, Vice Chair Holmes, Ranking Member Russo, and members of the House Health Committee. Let me begin by thanking you all for allowing me to speak here today. Let me also thank you and some of the other people in the crowd for having stolen half of my speech here, but that's all right. Repetition is key. I would like to voice my support for the proposed legislation. As a practicing infectious disease physician, I recognize the importance of shared decision-making between clinicians and their patients. Indeed, the American Medical Association's list of patients' rights codify the importance of self-determination. I believe it's Section B of this proposed legislation that merely restates what we all know to be true. Patients make the best choices for their health when they're informed and empowered as opposed to coerced. This legislation, as far as I understand, was crafted in response to ideas being discussed at various levels of government and in various sectors of society concerning the need for a form of vaccine identification for COVID-19. I'd like to mention 3 reasons why I disagree with the public identification of vaccination status. The first is that, to my knowledge, there's really no mandatory intervention placed on the citizenry in regards to the other top causes of death in the state of Ohio, such as diabetes, heart disease, influenza. Instead, in the context of a trusted physician-patient relationship, people generally make decisions that are best suited for their unique situation. I see no reason to really deviate from this tried and true formula. The second reason is that vaccine status alone provides an incomplete portrayal of herd immunity. The threshold to obtain herd immunity is based really on how many people can be potentially infected by a single case of the disease. Most data that I've seen to indicate this reproductive number, as we call it, falls between about 2.5 and 3. That puts the herd immunity threshold at about 67 to 70% of the populace. Unfortunately, the message that has been made public is that immunizations are the only path to this ideal. In truth, this number is arrived at by adding together both people who are in receipt of the COVID-19 vaccine, but also those who have actually recovered from disease. To date, according to the state of Ohio data, about 53% of the populace has either recovered or received at least 1 dose of the vaccine. Importantly, though, this statistic does not include the upwards of 20% of all cases which could be considered asymptomatic cases of COVID-19. If that were included in those numbers, that number could be significantly higher. If these numbers do portend an attainable immunity goal, there'd be no need to foist a vaccination upon an unwilling member of society. The third reason actually concerns the length of immunity that one appears to obtain by either acquisition of COVID-19 or from the vaccine. The latest data indicates that people who have recovered from COVID-19 harbor immunity for at least 8 months. Indeed, the trend of the graph actually seems to indicate that people will have immunity for much longer beyond that. In a similar fashion, those that have received a vaccination seem to have evidence of immunity that lasts for at least 6 months, and again, likely much longer. If that's indeed the case, it would obviate the need to delineate those who received the vaccine from those who have not. In closing, vaccines have been a boon to societies around the globe. They have helped save millions of lives. However, I would echo the words of the writer and philosopher George Santayana. Those who cannot remember the past are condemned to repeat it. In 1813, the federal government passed the Act to Encourage Vaccination. Unfortunately, at that time, the landscape of society was changing and the public was becoming more distrustful of credentialed professionals. That act was repealed in 1822. Today, polls seem to indicate that less than 50% of the citizenry trusts local and state health departments. I've worked to build relationships with my patients, some of whom come from sectors of society that really don't have high levels of trust for the medical profession. I would loathe to see any of their private medical decisions be made public or they be discriminated against for having chosen a path of care that was best for them. I believe that this bill is timely and that it'll send a message that we truly do believe in the fundamental right of autonomy. Thank you. Can I decline questions?
Yes. Yeah, you sure can.
Is that a lie?
That's a lie. I'm a politician. We're allowed to lie. Committee, who would like to start questions? Ask a whole bunch now. We're on a time limit. Dr. Liston.
Thank you, Chairman. Thank you for your testimony and obviously the work that you do to build relationships with patients. So this bill you reference the American Medical Association and organized medicine in this. Do you have a sense of organized medicine's stance on 248 and whether you're sort of representing what that might be?
I myself do not. The colleagues that I have are pretty much all over the place in terms of how they feel about COVID vaccination and offering it to the public versus foisting it on the public. So I couldn't give you an actual trend of the medical profession.
I would love to tell you that ACP, OAFP, so American College of Physicians, American Association of Family Physicians, American Association of Emergency Physicians, and pretty much every letter I can think of has really come out against this bill, including nurse practitioner professionals, because of the harmful nature. But part of the challenge, I think, with it is the impacts on vaccinations overall. So this bill says that universities can't ask students coming into the dorms to get a meningococcal vaccination. As an infectious disease doctor, any thoughts about that?
So, again, I think when we talk about taking care of people, we try to develop a hierarchy, if you will, of how you approach patients. So what I've always been taught since medical school is the person in front of you comes first. I will have my thoughts, and they may be strong in terms of how do I actually care for this person, what advice should I give them, things like that. But at the end of the day, it's them, their autonomy, the issue of beneficence, the issue of letting them decide for themselves what should occur in their lives. I can't foist that upon them.
So in that setting, though, I mean, the university is simply saying, hey, this protects our student body.
Right.
The R naught on meningococcal vaccine, what is 10 or so? So one individual
Right.
who brings it into a dorm, on average, would infect 10
Correct.
with a bacterial infection that has a death rate over 10%, right?
Right.
So that one person's decision should they get it, lead to, on average, the death of one of her friends or people on the floor.
Correct. It could have potentially, so I'm not doing the proper, chairman lips to represent.
Yeah, sorry. I'm not
For sake of time, of course. Correct. So in that instance, I would, regard that as something that I would strongly recommend that they consider this vaccination. Now, to be honest, I take care of adults, so I probably would never see those people in general because they're quite young. But I would recommend that for them. But I cannot foist that upon them. That's the difference, I think, of what this bill is trying to deal with. That's my sense of it, at least.
Sure.
Does that answer the question?
So, and then the university, who would think about all of their students, knowing that one person not getting it could lead to the death of someone on that floor, just numbers-wise, doesn't have the right to ask for vaccination status.
According to this bill, that'd be correct.
Okay. And what your beliefs are as well. And,
No, actually, to
Yes.
clarify, they have the right to ask. They don't have the right to force, I think is the difference here. So I
line
think that's-
111 says not ask, not request.
They can have a written policy, but it can't be a mandated policy because that's just forced discrimination, I believe.
Well, so again, would love the clarification on that in the future, maybe from LSC,
Right,
because
yeah,
line
we'll do that.
111. Anyway, thank you very much. I appreciate it.
I'm just trying to center it back to this is a freedom of choice, non-discrimination bill. That's the whole point, and everybody's done a great job. I'm proud of everyone. Ranking Member Russo.
Thank you, Chair, and thank you, Dr. Bhat, for being here. So, my question, I want to bring it back to, you work in a healthcare setting as an infectious disease doctor. I mean, in a healthcare setting, particularly in a hospital, the amount of resources and time that we spend trying to prevent nosocomial infections in the spread of that in a healthcare setting. And one of the approaches, other than wearing masks and the disinfection, one of the approaches is that many facilities do require vaccinations for their employees because of the patients that you're treating, the setting that we're in. So, again, this bill would prohibit, even in healthcare settings, those employers from, requiring that to protect patients and their other employees. And I guess I would like for you to respond to that, as an infectious disease doctor, and knowing how much effort and energy is put into preventing nosocomial infection spread in a hospital setting, how that it gets reconciled.
Right, so you're correct. Over the years, several studies have shown that the vast majority of nosocomial infections are somehow tied to the hands of healthcare workers. It's our fault, right, iatrogenic. So one of the things that was interesting to me was that earlier on in this epidemic, well before we had vaccinations, there were studies that were performed in hospital settings compared to the general citizenry that said, who's actually getting COVID, right? Forget about giving, but getting COVID. And they found that, the healthcare workers, because of all the masks and the gowns and everything that we wear, we're about 50% less likely to acquire COVID, even though they were in a COVID ward, compared to the people that are out there mixing with other people. So then you start thinking, well, in general, once an infection control program gets a hold of something, it becomes very difficult to wrest it away from them. So I'll be very surprised over the course of the next year or two if healthcare systems, clinics, things like that, actually start telling their workers, you don't have to wear shields, you don't have to wear goggles, you don't have to wear masks, because we wear them universally for every patient now. The COVID patients, we wear an extra gown and an actual shield, not necessarily a goggle per se. So I think it's really more of the mechanical barrier that's going to really lead the way in terms of protecting both the patients that really don't want to get disease X on top of their cabbage surgery, as well as protecting healthcare providers themselves when they're in the inpatient or outpatient setting.
So quick follow-up through the chair, Dr. Bhat. Actually, I agree with you. I think that, what we've seen happen in hospitals in the last year is a real case study. And when you do infection control properly with the proper equipment, we've seen, I think, a tremendous reduction in just overall nosocomial infections and spread, and particularly when we saw it with COVID. That said, the level of protection that is necessary without the vaccine to make that happen, I don't think on the flip side of that, we're going to expect businesses, for example, in the general public, to require their personnel, to continue to be masked or ask their customers. We've even seen it now. People can go in without a mask, and we're in this room without a mask in settings, and partially that is, not partially, that is due to the fact that our vaccination rates are increasing. So it's what is the... Either we go through the steps to prevent infections with mask, gowns, et cetera, or, we ask people to be vaccinated.
Yeah, and I think the only thing I would say to that is to appeal to history. So when you look at historical issues related to infection control, we've never really taken infection control in the hospital setting and taken it out, even to the outpatient clinics. That's been very uncommon. So to put it out into the public, that's been very rare that I've ever seen, at least in my lifetime. So for example, we don't really talk about this in the context of flu season, where we ask people who are going to Myers or Menards to wear a mask, for example. We've never done that before, to my knowledge, or for any other infectious disease for that matter.
Through the chair to the doctor, but you would agree that this is a once-in-a-lifetime pandemic situation that we're talking about with COVID?
Yes, it's
we've certainly had other pandemics, but not to the extent that COVID-19 has ravaged the world.
Unless you're 100 years old.
Unless you're over 100, which yes. No one in this room is. Thank you.
Representative Gross.
Chairman, to Dr. Bhat, thank you so much. When you think of immunity in a population such as Ohio, is the medical opinion that the only way to achieve immunity is through immunization?
No. When you talk about immunity, there's different aspects to immunity. So immunity can be garnered by natural acquisition of disease, and that happens every year when people get different respiratory viral pathogens, certain GI pathogens, things like this. So no, I wouldn't say that immunization is the only way. Yes. So there are, estimates that up to, as mentioned before, up to 20% of people potentially could get COVID with asymptomatic disease. If you include the mildly symptomatic, that's going to bump it well over 60% of cases. Does that answer your question?
To achieve herd immunity, do we have both disease plus immunization, or do we only achieve herd immunity through immunization, as been reported and often put?
No, for any disease, you want to take a conglomerate of people that have had disease X, whatever that happens to be, and add it to the people that have been able to receive a potentially helpful vaccine.
So it's a false statement to say that only those who are immunized are immune.
Correct. That's right.
Representative White.
Chair Lips, Doctor, thank you for your testimony today and for providing those statistics and things like that. I appreciate it. One of the questions I had, though, if I'm understanding this correctly, you were stating that the masking of medical providers helped prevent them from spreading COVID in the hospital setting.
Sorry, acquiring. So these are people that have specifically been relegated to working in COVID wards, whether it's the ICU or non-ICU setting, and then comparing those people, those workers, to people that are just out in the general community.
Would you say that the spread as well was helped to be prevented based on their masking? Because my question is about, the one thing I wondered about the bill in relation to the healthcare setting was that you are not permitted to require someone to have a facial covering, and so I'm not sure if I'm understanding the language of the bill correctly.
Yes, so everything that they wear also helps prevent the spread to the next person, because once you leave a room, you have to disrobe, you have to clean the materials that you've been using, the mask, whatever it happens to be, before you go to the next patient. So there are wards, nowadays at least, there's wards where you'll have COVID, non-COVID, COVID, non-COVID. Well, when you leave the COVID room, you have to disrobe and change things before you go to the next room. So yes, to answer your question, yes, that has reduced the spread as well.
Thank you.
We're out of questions, so we still have a few people that want to talk, but you're using up the time committed to the additional people, so I'm going to ask you to be brief, Dr. Liston.
I know this is brief, but I think everyone would love to hear your response here. We had some discussion about VAERS and the reports there, and the CDC's conclusion that of those 4,646 potentially after immunization deaths, a review of available information, death certificates, autopsies, medical records has not established a causal link to COVID-19 vaccines, and there's been some skepticism. Do you have any thoughts on the CDC's analysis of the vaccines?
I do not have much thoughts on VAERS. I have very little interaction with VAERS. I have tried to use VAERS a couple of times, and I think other people have succinctly stated that it's very laborious and difficult to navigate. So I can't really speak to issues related to VAERS.
But would you trust the CDC's analysis of the reports using their death certificates, autopsies, and medical records?
If they release the methods by which they've analyzed those, that's what I like to see, is their actual data. Like, how did you actually analyze these different cases? That's what I do. I look at data. That's what most physicians do. So I'd like to see, I don't want to take people at face value, not to say that they're being dishonest or lying, but I'd like to see, well, how did you come up with that? Because anytime you're going to put a publication out there, it should come under scrutiny to see, have you done it validly? Because
And has typically CDC done things validly?
So my experience with CDC is mostly in the area of international travel medicine, Yellow Book, those types of things. Those have been pretty good. In terms of COVID-related issues, I rarely actually go to the CDC because there's other resources and personal experience and people that I have that are colleagues that are knee-deep in COVID that I learned from, people on the ground rather than people in Atlanta, if you will.
Okay. So you doubt their methodology at this time?
I can't say I doubt it. I'm just not familiar with it because I don't know what their methodology is.
Okay. Thank you.
Thank you.
Representative Young.
Goodbye.
I thought it was 10 minutes.
Representative Liston scared you off there, but I'm joking. Is the COVID virus a virus or a disease? Because it started out in the narrative of fear to be a virus, and then it turned into a disease. So what is it?
So novel coronavirus, or SARS-CoV-2, is a virus of the coronavirus subfamily, kind of related to the old SARS we had about 2006, 2004, somewhere in that area. So yes, it is a virus that causes a disease in humans. The issue is that there are obviously certain sectors of society that have what we call a hyperinflammatory state. So this virus seems to infect people, but then those people that have that hyperinflammatory state, uncontrolled diabetes mellitus, heart disease, obesity, these types of things, it just sets off our immune system to become hyper-responsive, and that's kind of what sets things in motion for patients.
But it's a virus.
Yes, I'm sorry. Yes, it's a virus.
Okay.
Ranking Member Russo.
Thank you, Chair. Thank you. While I have you here, I mean, we've talked about this issue of vaccination versus natural immunity. Can you please, given your expertise, talk about the role that some of the variants that we're seeing emerge where we see natural immunity because they don't have access to the virus? What happens with the variants and some of the mutations and what we're seeing in other countries where they don't have access to the vaccines like we do here in the United States?
Right, so typically what I've seen is once you get virus X, many viruses, they just have a natural path of mutations. So when you talk about the India strain or the Great Britain strain or whatever, it's not that those were necessarily isolated to those countries and then imported here. They just discovered it first, but we have it here. So when you talk about countries that don't have access to the vaccine, can people get reinfected with COVID? Yes, they can get reinfected with COVID, but the data seems to be all over the place. Some people, because they have pre-existing immunity from having had COVID before, they'll respond very quickly and get over it. Other people seem to have a spiral effect, and nobody can really delineate why, at least from the data that I've seen.
So real quick to that, but what we are seeing with some of the variants certainly is that the vaccine provides more protection than the natural immunity. Is that correct to say with some of the variants?
That would be difficult to say. I haven't seen a lot of data specifically with reinfected people where researchers have delineated original variant, second variant, third variant, and said, well, let's measure their immunity levels. I haven't seen that data come out yet.
Okay.
But in relation to vaccinations, the vaccinations do seem to have pretty good, robust effectiveness against a variety of different variants.
Okay, thank you.
Doctor, thank you for being with us today. We heard about nosocomial infections or invasive fungal infections being common. Or is there a vaccine for MRSA?
No.
Is there a vaccine for C. diff?
No, it's not released, and it kind of keeps running into roadblocks, so no.
Is meningitis a known side effect of vaccines?
Wow, that would be a very uncommon, but yes, it can be a known side effect.
Thank you for your patience today. Thank you for your professionalism, and thank you for sharing with the committee. Oh, Representative Catrona.
Thank you. Through the chair to the witness. First of all, I appreciate you coming down here, and I myself, I run the only infectious disease medical practice in 3 counties, Trumbull, Mahoney, Columbiana County. And so one thing that we saw was about 33% of our intake in the hospital was actually coming from nursing homes and places like that. And I'm sure you probably had something very similar down here. You're from Columbus?
Yes, early.
In the Columbus area. So do you think it's a concern that if you have people that are working in those types of healthcare facilities, whether it is a hospital, whether it is a nursing home or long-term care facility, do you think that it could be a potential problem or concern if there are no vaccination requirements whatsoever for the caretakers or for the people that are working in those establishments, the nurses, the physicians, things like that? I'm curious to see what your thought is on that.
Yeah, it's a good question. And I think the difficulty with answering the question is that there's vaccines to a variety of pathogens that are out there. So you really want to delineate in your population, in your nursing home, what would they be at greatest risk for based on their age, comorbidities, things like that. And those are the things that you'd want to say, we probably want to see if our workers would get vaccinated. My sense is, just being in the medical field, is that most people that work in the medical profession want to do no harm. So they're willing to say, I'm going to get vaccinated for the protection of my patients.
And just to follow up with that, so with this piece of legislation, though, it would basically prevent that from happening. So I just, from what you were kind of indicating, I was just curious about that.
Yeah, so I could be wrong, but my understanding is it wouldn't prevent people necessarily from getting vaccines, but it's more of a communication issue, privacy issue, saying, well, I got it, but it's none of your business. I could be wrong about that.
So, and I'm all about privacy and in healthcare privacy. My understanding of the legislation, though, is that, an employer would not be able to say to work here in this, in this facility, in this hospital, in this long-term care facility, that they would not be allowed to make that a requirement. So like in St. Elizabeth Hospital, for instance, I don't know if you're familiar with it, in the Youngstown area, they make it a requirement that people have the flu shot to work in that facility. So, my only concern, I guess, or my thought is, I like you, want to make sure that the best care possibly can be given. I just, with this legislation, I think that, that might create a carve out for that, so that therefore, there wouldn't be the ability to say, hey, if you're a physician, you want to work here at this hospital, you must receive, X, Y, Z. Do you think that could potentially be a problem, given your experience in ID and your experience in the healthcare industry?
I think for the minority of workers, they may choose that route. But my experience has just been that the vast majority of people that work in that setting would say, I think I should get this.
Good point. And I would just say, and I can't speak for every place in Ohio, but back home, I think roughly we're looking at about 40%, though, that, or basically it's going, so you have physicians, which is something like 95% have gotten the vaccination, and then you go to nurse practitioners, something like 88, 85%, something like that. And then as more and more you go further down, it's less and less, so then you have nurses, and then, if you go down through that line there, you're seeing less and less people actually getting the vaccine. And so, when I think about nursing homes, I'm thinking, if you have like nurses' aides or you have anything like that, and they're around these people that are extremely vulnerable, as you know, that could potentially be, just if that would be potentially a problem, if nobody was going in there getting vaccinated because of that. So
right.
Thank you.
Yes. So the other thing to think about is on the other left side of the ledger, are the patients themselves getting the vaccines to protect themselves, right? And then if you look at the nursing home, for example, as its own subpopulation, I guess, then you'd want to say, well, what's the critical threshold for us to make sure that we don't have any types of outbreaks or hurt any of our patients? And that has to be done at that level, obviously. And then the third aspect, which we've talked about before, is a little bit when physicians, nurse practitioners, whoever else goes in to see patients, what are they doing in terms of on top of universal precautions anyways to prevent spread? So we don't want to necessarily treat vaccinations as a panacea, as if they're 100%.
Yeah. All right. Thank you. I appreciate your time.
Welcome.
Final question for this witness, Representative Lepore-Hagan.
Thank you, Chair. Welcome, Doctor. I'm baffled. I am. I mean, you are a doctor. You know so much more about medicine than I do. How can you say my independence, my freedom is more important than what your knowledge and everything you did to get to where you are? I think that how can you weigh that? Is that disingenuous to your patients? Thank you.
No, so that would only be disingenuous if I didn't offer my book knowledge or offer my advice or offer my experience. But at the end of the day, I think it really depends on that person that I'm dealing with in front of me as they go off to their community that I don't live in, the people they interact with, their sphere of influence, if you will. So I cannot speak to that level of insight. Only they can know that level of insight, if that answers your question.
Thank you so much for being with us and sharing your expertise. We really appreciated having you. Thank you.